Good morning, everybody. So, I would like to apologize for the fact that Dr. Abhijit who is actually our biomechanics and imaging expert, was not able to make it for the meeting. So, I work closely with him on a lot of these biomechanical things that we do at the hospital. So I'm going to sort of do his talk. So why are we even looking at biomechanics in the first place? So there has been, as you all know, since the time refractive surgery has started, a lot of talk on how that will finally affect, say, pressure readings, intraocular pressure readings by various instruments. And there has been a lot of advancement in development of various tonometers that would bypass the so-called viscoelastic properties of the cornea and get you more accurate, sort of real-time sort of pressure readings of the eye. And biomechanics are also important from the time of radial keratotomy, when people started finding out that the cornea and the rest of the eye inherently became weak after doing refractive surgery. So basically, biomechanics will help us evaluate the biomechanical nature an idea about the hydration of the tissue corneal structures, and also the stiffness of the fibers. This is also important from the point of view that people found out that central corneal thickness may not be the only parameter, or maybe not be the ideal parameter to evaluate, because a lot of studies have actually shown that central corneal thickness is not sort of a reliable parameter, and there are not strong correlations with, say, unit intraocular pressure in some cases, and also not with the, say, progression of disease in, say, glaucoma and etc. Although it is an important parameter from an epidemiological point of view. So it also, biomechanics also will help us look at, the patients who may progress in terms of disease. What is the treatment efficacy of a particular procedure, etc. And we need to sort of think about developing real-time evaluation tools for the clinician, and by doing more image processing, etc. So we all know what Nernst model is. Basically, if a material is stretched, there is a point in which it gets stretched, and then there is a strain, and then after that there is actually a drop off of that strain, and it's actually a comparison between stress and strain, and that actually represents the stiffness of the tissue. And a higher or more stiffer tissue like steel would actually take strain better than, say, tissue like, say, rubber, or structure like rubber. Now, if you translate this into the ultrastructure of the cornea, this image on the left is a 2D constructed image of the, it's actually a 2D constructed image of the retina of the cornea, and as you can see here at this point, these have been actually modified into this big picture here. So it's a 2D construction of the fiber distribution, and across the central cornea, it's more of a star-crossed sort of construction. As you go peripherally, the fiber distribution becomes more disoriented, and depending on the depth where you actually look at this, there is a difference in how the collagen is actually oriented and distributed. In posterior stroma, it's more sort of linear, whereas in the mid stroma it becomes randomly oriented. So in diseased eyes, like, say, with the keratoconic cornea, there are blank areas in the center, and that's basically a representative of the disruption of the collagen. And if you look at soft tissue biomechanics, the response to strain and stress is non-linear, which means that, say, if you increase the stress of the cornea by increasing the intraocular pressure, the response, or rather the way the cornea responds back to that or comes back to normal, is different in a normal eye and a diseased eye. And the time difference, or rather the the time it takes to stretch and comes back to the normal position is actually what the hysteresis is, the area between the two curves. And so that space there is actually hysteresis. And the machine like what we have right now, more commonly in clinical practice, like the ocular response analyzer, is actually not measuring the true hysteresis, which I will show on the further slide, but actually it measures the difference in the intraocular pressures at the time of the initial compression versus the time the cornea comes back normal. So even with soft tissue biomechanics, the importance is in conditions like myopia. The response to strain is more so in a myopic eye because the walls are thinner and the globe starts stretching. And this is what the case is in terms of a young person or young child with myopia. Adaptive mechanisms with myopic eyes happens. What happens is that as the eye cannot focus on a structure, the globe starts stretching, and this causes weakening of the sclera and thereby lengthening of the globe as well. So the challenges here are to sort of apply all these in vivo and to sort of use this parameter to distinguish, say, normals from say, diseased eyes. And the methods have to be based on in vivo imaging and mechanics of the collagen. So one of the machines that we have been using for the last 2 years in our hospital is basically an air puff Corvus ST, also a tonometer, which is very similar to the ORA and gives us sort of the deformation of the cornea over when an air puff is applied to the eye. So in many ways it sort of gives you hysteresis, although it doesn't give you a hysteresis value, because the hysteresis value, as you all know now, is actually mathematically calculated. So basically what it does is there is a deformation of the apex of the cornea from the time the first pressure is applied to the point where the pressure is let go, and this deformation apex actually then gives you the amplitude of deviation or deformation of the corneal apex, and that is actually measured by the device. And various variables like the deformation amplitude and highest concavity, which means the maximum displacement of the cornea, is actually measured with this. And it also gives us the corneal velocity and intraocular pressure and a pachymetry number. So the corneal velocity of the apex can actually deviate across a point in time. So this is what we mark here as applanation 1, and this would be the deformation, and then there would be the second applanation. So, and that is the applanation time. This, of course, we all know is the ORA, and unlike the ORA, the Corvus actually reports how much the cornea moves in response to strain. So one of the inherent differences between the two devices, the Corvus helps you actually look at the deformation of the cornea, which has some physical meaning to the, say, the biomechanical engineer, or even someone, say, that we would be able to later apply, because it actually gives some linkage to the corneal biomechanics. And the ORA only reports the intensity of the reflected, infrared light, and has no link to the tissue biomechanics. The Corvus actually helps capture information during the entire applanation cycle. You're actually seeing variations in the deformation over the period of applanation time. And that is actually not picked up by the ORA, because it just gives you a value. It just calculates from that a mathematical model of when the deformation started and when it became normal. And that value, that the time that I showed in the earlier slide, that is what is provided by the ORA. So it's just a number from a mathematical model with the ORA. And with the Corvus, advanced mathematical models can be developed to actually evaluate the biomechanics of diseases, and this is obviously not possible with the ORA. So both devices, this is something you have to keep in mind, that report data heavily influenced by intraocular pressure and also by the corneal biomechanical properties. So where is the future of this? So as we all know, the eye is composed of very soft tissues. And we have actually looked at, there have actually been reports which are in the last slide, looked at the corneal, just not the corneal biomechanics, but optic nerve head or the laminar preversal biomechanics, and this is the way to go, because you're looking at newer parameters to see how treatment can be changed. And so the goal would be to then describe the biomechanics with proper mathematical models and link that with biological response to the disease, and then from there on to the to treatment, and how we can actually maybe think about applying this knowledge to modify treatment and look at other ways other than just intraocular pressure in sort of either evaluating the disease, or evaluating progression, or in regulating or preventing progression. Thank you.